Today's Strategies for Caring for the Caregiver, the third and last in the series about dementia. I'm so happy to see all of you here today in person, as well as many people on Zoom from all over California. All of you who have registered will receive a link to today's recording, as well as the previous 5 programs periodically in the future. Please feel free to share the recordings. The information is so necessary, as you all know, and there are a lot of people out there who don't know what they don't know, and there's too much to know. A couple of housekeeping reminders. Please turn off your cell phones now if you haven't already done so. Thank you. And you know where the restrooms are, right? I want to thank the KOH Library and Cultural Center and Director Talia Berger and her dedicated coworkers, Joanne and Dwight Freund, and the National Council of Jewish Women Sacramento section for all the support they have given us for the whole series, which started in October 2023. Boy, time has flown. After the presentation by our speakers, you'll have an opportunity to ask questions from the floor as well as from the Zoom chat room. And now, why are we here? Today, you will be given up-to-date information so you'll know how to take care of yourself if you are now a caregiver or find yourself in that position in the future. And you will hear why taking care of the caregiver is as important as taking care of the person with dementia, if not more so. More than 11 million to 48 million Americans provide unpaid care for people living with dementia. Let me repeat that. More than 11 million to 48 million Americans provide unpaid care for people living with dementia. On average, a person with Alzheimer's lives 4 to 8 years beyond diagnosis, but they can live as long as 20 years. That's a lot of caregiving. As more people become caregivers, perhaps for many years, they face the mounting emotional, physical, and financial stress of caring for a family member or loved one, which can put their own health at risk. To help you understand why and how to take care of the caregiver, I'm so pleased to welcome back 2 wonderful women who will again share their vast knowledge, expertise, and stories of their experiences with dementia and caregivers. Dr. Barbara Gilogli has a PhD in human development with an emphasis on aging from UC Davis. She's also a credentialed professional gerontologist and the retired chair of the gerontology department at American River College. Dr. Gilogli is currently in private practice, working with older adults and their families. Dr. Jan Rogers was a Kaiser physician for 31 years, is now retired, and is board certified in geriatric medicine, as well as in hospice and palliative medicine. Dr. Rogers is currently teaching at California North State School of Medicine in Elk Grove. After their remarks, they will answer as many questions as possible. And now,
how many of you are caregivers right now? How many have been caregivers before? Okay. How many of you have someone standing behind you who can't wait for your job? You know, I've asked that question many times and I have never seen a hand come up. And you all know why. It's probably one of the hardest jobs in the world. And there is nobody who wants it. And if you're from a large family, they're all celebrating the fact you're doing it. But the sad fact is there is no one behind you. Therefore, if you have a caregiver and a patient, the more important person is the caregiver. Because without you, that patient is lost. And that's really hard for caregivers to absorb and to believe that, because you're not a caregiver unless you care. And often we care more than we have capacity for doing that. So if something happens to you, this person is left probably with Adult Protective Services to find a place for this person. And that's not what you probably want. So when you think about that, when you're caregiving, the person you have to care for first is you. Because the best gift you can give that person that you're caring for is a healthy caregiver, because they depend on you. But you also have to be realistic about your capacity for caregiving. Some people have a capacity way out here. For others, it's like this. But that's just who you are. So if you are one who's got about this much capacity, you're going to be worn out faster. And you have to accept that. That's who you are. And you can't be different. So you have to be realistic about your capacity, because that's also a key for when you need help. So how do you care for yourself? Number one, caregivers are always tired. I used to ask the question, who here is tired all the time? All the hands are up. Because there are multiple things to do every day, and they're never the same. Remember, we talked the last time about being so unpredictable. So you can't really make a good plan of how to attack what's going on, because it changes constantly. So because you're always tired, you need to take the advice people gave you when you had small children. When they're asleep, you take a nap. But the problem is, when the children or the person you're caring for is asleep, you think, oh, this is the time I can get something done. But you really have to stop and think, if they're sleeping, maybe I need to take a nap too. And also, if it's just a few minutes, if the person you're caring for is napping, you nap. If they're watching TV, you go watch a different TV, read a book, relax. If the person's outside, you stay inside and kind of click off the caregiving switch. And that switch is the one that means you're always looking, you're always listening, you're always anticipating. True respite is turning off that switch. And that usually happens when someone else is taking care of this person and you don't have to think about it anymore. I see a nod. Sometimes you just have to go in the bathroom and lock the door if you need to take a breath. If you're so frustrated you can't do it, go in the bathroom. It's usually the only door that has a lock on it. The person may bang on it. You remember when you had small children, if you were in there, they were banging on the door. So the behavior, again, that you're seeing is childlike. They're adults, but the behavior is becoming more like children. One of the big problems is not being able to sleep as a caregiver. And if it's a spouse, you're in the same room and usually in the same bed. If the person is snoring or restless or talks in their sleep and you can't sleep, perhaps the best thing is to move into another room, or maybe it's the couch in the living room. But if you cannot sleep, you cannot take care of the person you're caring for or yourself. So sleep is important, and you need to find a way to get that. Another thing is to find a support group. Now I notice the lady in the back nodding her head. You have no idea how reinforcing that is to somebody. If you're in a support group for people who are taking care of someone with dementia, no matter what you say, the heads are going like this. And that's very comforting to know you're not alone, because caregiving is isolating. Your social life ends. Everything ends except caregiving. And if you can be with a group of people who understand what you're saying, it relieves some of that burden. So find a good support group, or find a therapist who works with families dealing with dementia. Now, asking for help if you're a caregiver is not easy. And the person you're caring for doesn't want anybody else but you. But if you're going to care for yourself, you often have to have someone else come in and relieve you. I know one time I was taking care of my mother. She didn't have dementia, but she had cancer. And I was also working, so I'd take off work to take care of her. But sometimes I had to be in the office. So I'd hire someone to come stay with her, and she was mad as a hornet. I don't need anybody sit there looking at me. I said, this person isn't for you, it's for me. Because if I go to work and I'm worrying about you, I can't get my work done. And besides that, I'm paying for it. And she said, oh, okay. So you have to realize that they may not like it, but they can get used to it. It's not a job you can do alone to the very end. People think they can, but you cannot. And if you can get someone to come in and relieve you for 4 or 5 hours for 1 day a week, you can get through the other 6 because you have hope. Next week on Tuesday, I get the day off. If you can get someone to give you a weekend, you can get through the next months because you have hope. But when you're dealing with a degenerative disease, there is no hope. It's not going to get better. So if you're caring for someone who's had hip surgery, they're going to get better probably. But dementia doesn't get better. So if you can get help for just a small part of the time, it can help you get through the rest of the time. So who are you going to ask for help? Well, usually the first group of people you're looking at is your family, because dementia's a family issue. And I believe you should give your children and your siblings an opportunity to understand that. Now, again, you have to realize who has the capacity and who doesn't. Some of the family will help you, and some of them, I'm telling you, will not. Sometimes it's geographic. I only had one sibling. My brother lived in Montana, so he couldn't come day by day to help. But he could help to pay for care, who could give me a day off. So that's an option for families who are far away or too busy. Maybe they could help pay for care for you for 1 day. And when we're dealing with family, I suggest you say, I need you to, not would you, could you. If you don't want no for an answer, don't ask that question. But I need you to makes it more difficult for someone to say no. Your next source would probably be friends and neighbors. Sometimes there's a neighbor who is just naturally helpful. And you can say to that neighbor, I need some help on a certain day. Would you be willing to do that? And if you can, you could offer to pay for their time. I have a friend who needed some help when she was recovering from surgery. And she did ask her neighbor, who she knew was living only on Social Security and was struggling. And she said, could you please come and help me? And I couldn't accept the help unless I pay you. So would you agree to that? And it worked for both of them. So check with friends and neighbors. If you belong to religious or fraternal organizations, sometimes you can put the word out. And there may be somebody in that group who also needs a little extra cash and maybe would be willing to come in 1 day a week for 4 hours, and you could pay them. You can also pay for private through agencies. It is not cheap. The going cost is somewhere around $45 to $50 an hour with a 4-hour minimum. You can ask other caregivers if they have any recommendations for somebody you might hire outside of an agency that they've had experience with. There is a very active Fijian community that practices caregiving. And my experience with them is they're very good caregivers. And the good thing, they have large families. So if your caregiver can't come, the sister or the brother or nephew can come and fill in for you. Another option is adult daycare or adult day health care. Now, there aren't that many around anymore, but there are some. Adult daycare is basically recreational. It's a place where the person with dementia is dropped off in the morning. They have activities, entertainment, they have a lunch, and you pick them up in the afternoon. There's also adult day health care, which has the medical component to it, where they also get physical therapy, speech therapy, and occupational therapy, and a nurse to be there to help them. Again, those are expensive, and there are few and far between, but there are some of them. So in-home help is the first step. When that's not sufficient, the second step is placement. And placement is something nobody wants to think about. Many of you may have said, I will never put you in a place like that. Don't ever make that promise, because you don't know what's down the road. Instead, say, I promise you I'll always do the best I can to take care of you, because that's all you can do. But placement is not a horrible thing. It's a way of saving the caregiver and providing the necessary care for your loved one. And that's your responsibility, is to see your loved one is being taken care of. Doesn't have to be you 24/7. Now, after placement, you're still the caregiver, because you're exactly the person the facility will call if there's a problem. And you're the connection between the person you place and the outside world, with the family. You're that connection. You provide that for them. What are the signs for placement? Well, one I've talked about. If you're dead tired and can't sleep, that's a good sign that the person needs to be placed. If there's a safety issue, if the person has become aggressive, and that happens more often than you think, because they forget, remember? And they may forget who you are. And they may wake up in the middle of the night and think there's some stranger in bed here with me. So I tell caregivers, always keep that in mind. Always know the relationship between yourself and the exit. Don't let that person get in between there, because you don't know what's going to happen. Not because they're awful, but because they can't remember. If the person continues to wander, goes out the door, maybe in the middle of the night, that's a safety issue. If the person you're caring for continues to get into the kitchen and turn the stove on, that's a safety issue. That's the time you need to think about placing that person. Also, if you develop resentment toward that person, and I'm here to tell you that's a normal reaction and feeling, and it's okay, but it's also a warning sign that perhaps someone else needs to help you with this caregiving. Constant fatigue, we've talked about. Worsening health on the part of either your patient or yourself. If the person is requiring more care than you can give, if the person cannot transfer with just one person and pivot on a foot, you can't take care of that person anymore, because you can't lift them up, and nor should you, because then you've got two patients, because you're going to be on the floor. So constant fatigue and worsening health for either one of you. So where do you find that help? Well, there are a number of large retirement facilities that have a continuum of care. One is independent. Another one is assisted living, where you may need assistance with medication, sorting your pills. You may need assistance showering, but you're still pretty able to take care of yourself. Sometimes a dementia patient who's not too demented at the moment can qualify for assisted living. The other is more daily care for that person. And then there's memory care units for people with dementia. And they're usually 12 to 20 people in a memory care unit. The other option is residential care. They're called RCFEs, Residential Care Facility for the Elderly. And it's a house in a neighborhood just like the house you live in, that's been modified to take usually 6 people. So it's called a 6-bed with 1 or 2 caregivers. In many ways, that's a better environment for somebody with dementia. Usually in large facilities, the staff is usually 1 to 10 or 1 to 12. In a 6-bed place, even if there's 1 caregiver, it's only 1 to 6. And it's a small environment, so they have more eyes-on care. There are many of those around. The last one is if the person is a 2-person transfer. If this is a person who needs medical care, then it's a nursing home, a long-term care facility. Now, all of these are expensive. So how do you pay for it? Well, of course, the first choice is you pay for it privately. Now, there are a few of us, normal people, who have the funds to pay from probably $6,000 to $9,000 a month, every single month, to take care of 1 person. Because remember, once they're placed, you have to pay for that, plus you have to keep up yourself. So how are you going to pay for that? Because most of us cannot do that. One is if the person you're placing is a veteran, you need to check with Veterans Affairs. There may be some funds available to take care of the veteran. Perhaps you or the person you're caring for have taken out long-term care insurance. Many of us have. It's expensive, but this helps in paying for the long-term care. For most people, it comes down to what's called Medi-Cal, which is Medicaid in every other state, but in California, it's Medi-Cal. And it's based on being low income. Now, if the person you're caring for is not your spouse, then you can look at getting this person qualified for Medi-Cal on the basis of low income. And what that would mean with whatever income they have, minus, used to be $40, maybe it's $50 now, a month is set aside for personal use. The rest would go to pay, and Medi-Cal would pick up the difference. Now in California, if the person you're caring for is your spouse, you can separate now your assets and shelter the majority of those assets for the well caregiver. Because the state realized if you didn't do that, you used to have to get divorced to do that. And somebody who's been married 50, 60 years is not going to get divorced. So what they wound up was 2 destitute people that the state had to pick up care for. So you can now separate those assets with an attorney to qualify the ill person for Medi-Cal. And then whatever income they have, they spend down, but not yours. And the attorney can legally shelter the majority for the well spouse. The main thing to remember if you're applying for Medi-Cal, do not sell your house. Your house is an exempt asset. If you sell it, the money is not. So if you sell it, you have to spend down that money, and then you have nothing. If you do not sell your house, it's exempt, and there will be a lien once the person with care dies, but you'll still have the rest of what's in that house. That's still yours. Now, I'm not up on how that may change in the new budget or over the last couple months. I haven't kept up with it. So I tell people you need to check with an elder law attorney if you're going to pursue that route as a married couple to qualify one for Medi-Cal. So check with an elder law attorney. Okay, I think that's it, Jan. You're next. Thank you.
Can you hold the write it down or remember it again because we'll write it down. I don't want to stop you. Thank you.
All right. Thank you, Barbara. Going to be talking about many of the same things. And so caregiving is a very, very, very huge issue for very many people in this country. Okay. I looked up to see, and actually, right now in this country, about 53 million adults are family or neighbors who are providing care for their older relatives, for their spouses, for their neighbors, friends, and they are providing help with activities of daily living. So they're requiring physical care. When we talk about activities of daily living, we include bathing, dressing, toileting, management of continence, so trying to maintain continence, eating, okay, and transferring from going from chair to bed, bed to chair, okay. So, so about 15% of the total population in the United States right now are providing care, family caregivers. And that's about 20% of the adult population. So 1 out of 5 people are caregivers. And 59% of the caregivers are women, okay? Because often the care you're providing for is the spouse, all right? And 43% of caregivers, of the family caregivers, are the sole care providers, which is just mind-boggling, okay? More than half of them, it was 56% of caregivers, also continue to work at full-time jobs. All right. So not only are they working outside the home full-time, they are working full-time inside the home, which can, of course, contribute to the fatigue and the burnout that Barbara talked about and we'll talk about again. Now, I looked up and was amazed to see that when you look at the average caregiver, the average person spends 26 hours a week caring for someone. So it's not just a couple hours here and there. It's a substantial time commitment. And a quarter, 27%, spent 30 hours or more caring for people. Okay. And of all of these family caregivers, about half receive no means of formal support for their caregiving. So let alone they're not paid, they're not participating in counseling or support groups, and they're not receiving respite care. So they're doing it on their own, which is just amazing to me. So, there are many, many health effects of caregiving. And we always think of all the negative effects because those are, of course, the most common. There are some beneficial effects that are seen with caregiving, and I do just want to touch on those. Sometimes, depending on the circumstances, the caregivers actually feel like they're in a little bit better physical health, being more active and providing care for people. So that can be a benefit. In some circumstances, especially with family members, they feel the self-esteem and they feel really good about what they're doing. And I've had a number of caregivers when I was in practice who actually told me about what a blessing they saw it, that they had the opportunity to mend fences, to be able to help out their family members. So there can be some beneficial effects to caregiving. Okay, they're not always obvious, but sometimes actually providing caregiving can help strengthen family relationships. So, so that can occur. And I don't quite believe the statistic, but it said about a third of caregivers report no strain or negative health effects. I think that's way too high. So I think that's got to be, yeah. I never met any that said that. So there are both physical and mental health effects that are associated with caregiving. Okay, so the physical effects, obviously fatigue is a big one, exhaustion. Okay, fatigue. And interestingly enough, there has also been shown that immune systems don't function as well when you're working as a caregiver. So you're more prone to infection yourselves when you're acting as a caregiver. Okay. Your risk of chronic disease, like heart disease, cancer, diabetes, arthritis, your risk of those illnesses increases when you're acting as a caregiver. Okay, whether it's associated with the stress, the physical work, it's not really known, but there is an increased risk. Weight gain is often something that is seen. Now, I've seen weight loss in caregivers as well, but weight gain is a fairly frequent one. And back and joint pain, because most of the time when we're providing care, we have our own joint issues. And so those are very, very commonly seen as physical effects of caregiving. But the mental effects are really sometimes even more prominent. Okay, so depression is one of the most commonly seen effects. And 40 to 70% of caregivers report at least some symptoms of depression. Okay, and anywhere from 25 to 50% of them actually meet criteria for major depressive disorder. So it's very, very common to experience depression when you are a caregiver. Okay. Other mental health effects that can be seen are anxiety. About 10% actually meet criteria for anxiety disorder, understandably. Okay, but anxiety goes along with it. That includes panic attacks. Right. We talked about the overall feeling of chronic stress. That is extremely common in at least half. And one of the things that is seen very, very frequently in caregivers is a condition that we call burnout. Okay, where there is emotional, physical, and mental exhaustion. All right, they are burnt out, and that's due to the prolonged stress. And that is seen in more than 60% of caregivers. So that is a huge effect. In addition, Barbara mentioned some of the others: isolation, distressed. There's often decreased subjective feelings of well-being. You don't feel very good much of the time. Insomnia is a big problem. Even when you are able to go to sleep, you think, especially when you're caregiving for someone with dementia, you're on high alert, especially if that person wanders. You are just worried that they're going to get up and fall, or they're going to get up and need something. And so even when otherwise you would think, okay, I'm ready to go to sleep, sometimes you're just remain on high alert overnight. So it's very, very, very common to see insomnia in caregivers. Okay. Sometimes caregivers have difficulties focusing, difficulties with short-term memory. They're just on overload. Okay. Sometimes they don't take care of themselves. They skip their own appointments. They skip their own medications. They skip their own personal hygiene. You know, it's really hard as a caregiver to get in and take a shower and wash your hair, and when you're worried that someone is going to fall or wander. Okay, so it's very, very common. Sometimes brushing teeth is one of the tasks that is frequently skipped by caregivers. They're helping the other person brush their teeth, and then they're done with that. So it has huge ramifications for the caregiver. And the physical effects of caregiving are generally much less intensive than the psychological effects that are seen. Okay. The other thing that is not surprising is that if you are caring for someone with dementia, okay, that is much more challenging and causes even more distress than caring for someone who needs physical help alone. Okay. Now, I'll just tell you a story about a home visit where I met a caregiver. I went in to see the patient to make a routine visit, and the patient herself was actually bedbound. She had severe dementia, and that kind of surprised me. I wasn't expecting that degree of dementia. So she was bedbound, and she was essentially nonverbal. So I couldn't get any history from her. She was just lying in the bed. And so her daughter was her caregiver, and her daughter was coming in and out of the apartment frequently. You could tell she had a lot going on. And so I would wait, I would do the physical, and then I'd wait for the daughter to come back in, and so I could get a little bit more of the history. And she gave it to me in very quick clips, and she'd go out again. And so when she came back in, I actually sat her down and I said, "How are you doing?" And she just looked at me and she got angry. And she said, "I'm not the patient. Didn't you look at her chart before you came? It's not about me." And she walked out again. And so I stayed in with the patient, continued the exam. And after about 20 minutes, she came back in and she said, "Can we talk?" And we went into the living room, and she said, "I really am sorry. I didn't mean to say what I did." She said, "Nobody has ever asked me before how I was doing." She said, "So I really hadn't thought about it." And she said, "Once I did start thinking about it," she said, "then I realized why you were asking." It turned out she was working full time, okay? And she had a lot of stress going on associated with her job, the rest of her family, on top of her caregiving. And so we were able to speak a little bit, didn't get into too much detail right away, but she clearly was experiencing burnout. She was burnt out. She was overwhelmed. She had a number of symptoms of depression. Okay, I was very worried about her in terms of her depression. She also sounded like she had anxiety. She was experiencing insomnia. Okay. And again, she said she really hadn't thought about it until we started talking. So that's just one example of the effects that can occur in caregivers. And like Barbara said, what can lead to placement? And when you said that, actually, I just flashed back, even though I was a kid at the time, I flashed back to when my grandmother was caregiver for her spouse. My grandfather had what we'd now call dementia, but it wasn't called dementia at the time. It's called hardening of the arteries. That's what's on his death certificate, okay? So he had all of the classic signs. He wandered all over, and they lived in San Leandro, right off of Davis Street, a very busy street in San Leandro, and he would wander frequently. Okay, the police knew where he lived. They would pick him up and bring him back. He was very aggressive with my grandmother, which added to her stress because she said, you know, he was the kindest, gentlest person before he became demented. But with his dementia, he was get very, very physically aggressive. Okay. And I remember her, even as a kid, talking about, I don't know how much longer I can do this. And they had essentially no money. So that was finally was one of the many times that he was brought back by the police, and actually the police officer sat her down and said, something has to change here. Can't keep doing this. So that was when he was ultimately placed in a nursing home for the last few months of his life. But that's going on a lot out there. And so it's very, very, very challenging to be a caregiver, particularly with caregiving for someone with dementia. Okay. So as Barbara talked about, there are some strategies that we do use and encourage people to use to deal with the health effects of caregiving. So prioritizing self-care is crucial. It is very, very important, as Barbara talked about, to care for yourself. Take your breaks when you can. Address your symptoms. First, acknowledge them, the fatigue, the anxiety, the depression, and then address them. Okay? And to try, even though it's very difficult, to maintain a healthy lifestyle while you're doing this. It's very difficult, but you need to try to take some time for yourself, as Barbara talked about. It's crucial for caregivers. And some specific strategies that she mentioned and that exist include taking time for regular exercise, walking, for relaxation, for meditation, yoga, Tai Chi, something in a day that can help you focus on yourself and relax. And taking the breaks and the respite, as Barbara talked about, and being kind to yourself, acknowledging what you're doing and being kind to yourself can help go a long way. It's really important to adjust your mindset when you're a caregiver. So, just practicing acceptance is very, very, very important. Focusing on the positive aspects of caregiving, which sometimes are not very evident, okay? But focus on what you are doing for your loved one. And, celebrating your efforts. You're doing a lot. And acknowledging that is very, very important and can help with some of the depression and anxiety. So connecting with others, again, very, very important. Friends, family, professional guidance. If you need to talk to a therapist or a counselor, that's really, really important, and that can go a long way. Considering support groups, which are very, very helpful. Okay. And then again, asking for help, family and friends, hey, I've got something to do. Can you cover for 4 hours today? And that helps increase the awareness in the family when you do that too, of what you are doing, and actually can help get some more participation from other family members at times. So help from them, from senior centers locally, from local agencies that are available, Alzheimer's Association, that sort of thing. And it's very, very important that you acknowledge your responsibilities and try to manage them. So setting realistic goals, realizing, you know, hey, I can do this for this amount of time, but I am going to need a break, just as you talked about. So, and a respite can be for a few hours. Sometimes it's for a few weeks. Sometimes respite care really needs to be built in order for the caregiver to continue doing it. So specifically, when fatigue is an issue, which is pretty much in the majority of caregivers, there are some strategies that we advise to try to help caregivers to cope with fatigue. So we talked about exercise, relaxation, getting adequate amounts of sleep, eating a healthy diet, trying to stay healthy yourself, okay? And again, joining a support group, asking for help, taking breaks, using your respite care, and seeking professional help when you need it. Okay. For that patient I saw in the home visit for the caregiver, after we talked, I actually suggested to her that she talk to her primary care doctor about getting on an antidepressant because she really did meet criteria for major depression. And I think that that was really important for her to follow up on and talk. I said, you need to talk to your primary care and you may need to talk to one of the psychologists and or psychiatrists about everything that you are experiencing. She had significant depression. Okay. So those strategies can all help decrease the fatigue, which is part of the burnout. Okay. So Barbara talked a little bit about some of the resources and support groups. So she has this list here that I'm going to have you pass out. And there aren't enough, but there aren't enough resources, I mean, but Del Oro Caregiver Resource Center can be very, very helpful. The Alzheimer's Association, very helpful. The support groups that they have through the Alzheimer's Association are very, very helpful. Sacramento County Aging Resources, and then there's some additional resources listed to get some help as a caregiver. Now, just to touch on some of the placement options that Barbara had talked about, you mentioned pretty much everything. So what generally happens is that, in my experience, once people hit that point where they finally decide, I need to place this person, the majority of people assume that, okay, they need to go to a nursing home. Okay. But unless they are on Medi-Cal and meet the qualifications that they need assistance with all of their activities of daily living, they won't qualify financially to go to a skilled nursing facility for custodial care. Okay. Sometimes that happens, but not very often. And the majority of caregivers just assume somebody's got to pay for this. You know, I mean, it seems like society should, but that's unfortunately not the case. So what generally happens is that the other options, the assisted living option, the memory care facility, the residential care, those are all options for care. They are not cheap, as she mentioned. So long-term care policies, using some of their funds to pay for that. They're definitely cheaper than a skilled nursing facility. Okay. It's almost $10,000 a month to pay for a custodial bed in a skilled nursing facility these days. Okay. So who can afford that? You know, no one. Yeah, exactly. So, memory care facilities, as Barbara talked about, very interesting. And usually the staff who are working there are trained to work with patients who have dementia. So they usually are pretty good at interacting with the patients. And the activities that are available in a memory care unit are better geared towards people with dementia than if you put them in assisted living. Okay. They can't do complex embroidery or whatever the activity might be in an assisted living facility. The activities are geared towards people with cognitive deficits. So, so memory care usually is something that works a little bit better for people with dementia. And I was looking up just the average in Sacramento these days for a memory care facility. It's cheaper than the rest of the state. It's about $5,000 a month. Okay. The state average was about $6,500. So at least at this point in time, it's a little bit less expensive. But again, who can afford that?
When I looked, that is not.
And this was just average, yes. Oh, we paid a lot more for that for my mom, and that was, what, 14 years ago?
Additional fee for everything, so.
Yes, yes,
Diaper change.
yes,
That's a base price, and if
yes.
there's a $2,000 to $3,000 increase on that, so that's not a.
That's not the overall cost, no. You are exactly right. And I remember when we got my mom in memory care, they would say, okay, well, she needs to start out. She can't manage her meds. So it was $10 a day for medication management. Okay. All right, fine. So you're right. With each declining condition, with each level of assistance that she required additionally, there was an additional charge. So you're exactly right. So that is probably the base cost without all the add-ons. So in-home care is also an option if the patient qualifies for Medi-Cal, okay? In-home supportive services is an option where the care can be provided for in the home. It's funded by county, state, and federal money. And so it allows for people who are in the home to be, who are at very high risk for needing placement to be cared for in the home. Okay. They will actually pay, if there's a family caregiver, they will pay for that. It's not much. It's not even $19 an hour. So it's not very much, but they will pay. And if the family member is not available to do that, then there is a pool of IHSS workers out there that you can try to hire from. They're in huge demand. But again, that's if someone qualifies for Medi-Cal, and the majority of people don't. So that is an option if you're considering Medi-Cal. And as you mentioned, adult day healthcare. PACE program is a program of all-inclusive care for the elderly that is funded largely by Medicare and Medi-Cal. There are very few programs out there available. It's adult day health care plus they have usually physician care available as well. So it's an even higher level of care. But again, it's not something that most people can afford. There are 3 or 4 programs in Sacramento area that are available. So, well, one of the other things I just wanted to touch on was end-of-life care issues for people with dementia. Okay. We've talked about hospice and palliative care before, and both of those programs can be very, very helpful for people who have dementia, and they can help the caregivers as well. So hospice is appropriate when the patient is felt to have a life expectancy of 6 months or less. All right, so it's at the end of life. It's not providing that help when the caregivers really, really need it. But palliative care can also be helpful. And ideally, when someone is diagnosed with dementia, palliative care ideally should get involved and continue to follow patients. So as you mentioned, the life expectancy once dementia is diagnosed is anywhere from 4 to 8 years. So this is a long-term process and can be even longer, as you said. And so, but what does happen as people are approaching the end of life, there are a number of changes that occur that are part of what I see as kind of the slow dying process. And it even adds to caregiving duties for the caregivers. So not only as people are approaching the end of life with dementia, do they experience severe cognitive and physical decline, they basically require total care at the end of their life with dementia. So you have to assist them with everything. They can't walk. Most of them are bed-bound or at least chair-bound. And you have to provide total help. They become weaker, they're more frail, and they're at higher risk for falling. Okay, so there's more injuries. They often lose interest in eating and drinking. And what's really important to understand as a caregiver is when that happens, they are not hungry. Okay, so I can't tell you the number of home visits I made where people would say, but they're starving, we have to do something. And I could understand because I felt the same way about family members, but they're not hungry when they lose interest in eating. Okay.
Or they can't eat, they can't swallow.
Yes,
Because my mother was
exactly.
like that, and you had to add, I forget what it was called, but you had to add something to whatever food it was to make it.
The thickener.
Exactly, to help it to go down, but even beyond that.
Yes.
You reach a point where you can't swallow anything.
Exactly, and they're at risk for aspirating. Oh, yes. Sorry, I keep forgetting to do that. Yes, saying that she was saying they can't swallow. What happened to her mother is they can't swallow, and that's right. They develop what's called dysphagia, the difficulty swallowing. Okay, and it's a process to swallow and not have it go down into your lungs. And so that process gets disrupted and they can't swallow. They often, especially at the very end of life, lose the ability to swallow. And I will tell you, I made a home visit to memory care unit because someone was approaching end of life. Okay, went to see her. I looked at her and I said, she's hospice appropriate. I mean, she was bedbound and she looked like she was at the very end of life. Okay. So referred her to hospice, talked to her daughter who was local about what was going on, shared with her some of that information. And so, of course, the daughter appropriately called the rest of the family and said, you know, mom's very close to death. So another daughter from Southern California came up the next day to visit her. She didn't really know much about, understandably, the dying process. So She was there at lunch. She had her own steak sandwich. And she thought, this is rude. I'm sitting in front of mom and mom's not eating. So she gave mom a chunk of steak from her steak sandwich. Okay. Of course, we know what happened. She choked. And actually, one of the memory care staff had to come and do the Heimlich maneuver to get that out. So there is a reason that we do not force feed people at this point in their lives. When they lose interest, it's not long after that they lose the ability to swallow. So it's very sad, but it's definitely very consistent. So, and they get more prone, more susceptible to infections as well. So you're seeing many more cases of pneumonia, of urinary tract infections. And because they're not moving, because they're bedbound, they're at higher risk for pressure ulcers. Okay, bed sores. Okay, so that's why you have to keep changing their positions when they're bedbound. They generally become incontinent. They lose control of bowel and bladder towards the end of life. And they may have more difficulty speaking, and they may actually not be able to communicate verbally at all. So using nonverbal methods of communication with them at this point, touch, is very, very helpful because many of them lose their ability to speak. And in the final hours, you'll see an even faster decline. So when you're down to days, hours to days, you'll see a faster decline in their condition. Their breathing may become very shallow, may be irregular. They may actually have periods where they stop breathing for short periods of time. And they develop very frequently what's called the death rattle. Okay. And what you need to know as a caregiver is that that is not distressing to the patient. It is distressing to everyone else. When my father had it, as he was dying, you could hear it at the other end of the house. It's due to the secretions building up in the upper airway. And so they are not distressed by it, but everybody else is. So we call that actually the death rattle. They may have dry mouth, again, partially because they're not eating or drinking. So that's when you use the swabs that you generally soak in water. Don't use the glycerin swabs that we used to use years ago, but it's the swabs in water that can increase the moisture. Okay. And please don't force feed them, as we talked about. And then frequently what you can also see, just so you're kind of aware of this, terminal delirium often occurs in the last few hours to days. So people can start hallucinating. They can become more agitated, restless, sometimes even more confused. And sometimes when they were hallucinating, I would ask them, what are you seeing? Oftentimes they are seeing visions of people who have passed on before them, family members. So it's amazing, but not always, but that can occur. And generally at the very end of life, you're going to start to see their hands and their feet kind of get bluish and their skin's going to get mottled. And that generally means death is fairly quick. And the other thing just associated with the dying process that I just wanted to mention, the last thing, is that generally speaking, people who are in the dying process often have a period of hours to a day at the very end of life. It's often the day before they die that I call it the good day. Okay. And there are a number of terms for it, but it's also called terminal lucidity. All right. A rally. But I always considered it such a gift for the family when it occurred, because even with dementia, oftentimes their mental clarity improves, like I said, a day or two before they die. And you can have actual interactions with them that you couldn't have had a couple of days before. So when you do notice that your loved one is having a good day, I always just advised, please call the rest of the family so that they can participate in this, because this is truly a gift. And then oftentimes once the next day is often the next day or the day after is typically the day that they die. But the majority of people, especially with Alzheimer's, will experience a good day in the dying process. So thank you.
Thank you so much, Barbara and Jan. This has been, I've done a lot of reading and study and so on, like I'm sure a lot of you have, especially since October 2023. But this was so much good information. And it just requires making that phone call to inquire, because you probably have to make a lot of phone calls to get more information. And sometimes I know for me, and I've heard from others recently, you make phone calls. I think, Carol, you were telling me this yesterday. You make phone calls about one issue to 3 different agencies, and they all have different answers. It's very frustrating. So you don't have a good answer at that point. So anyway, at this point, questions, and Holly has the microphone, so please speak into the microphone because people on Zoom can't hear you unless you're speaking into the microphone.
You think I would remember? Oh, I was supposed to write. I knew I was supposed to do something and I didn't. I was supposed to write it down. But come up with a question anyway. So you right at the end of, I'm sorry, I don't remember names too well
Jan?
either. At the name of, Barbara, at the end of your talk, you were mentioning about Medi-Cal and supporting various care institutions. And I wondered if Medi-Cal then influences your choice. In other words, do they, if you take this process of, let's say, trying to shelter some of the assets, and then you want to go into a really nice place, will Medi-Cal say, sorry, that's outside of our range, and so they won't support it at all? In other words, will they refuse to let you go to, let's pick a place out of the clear blue sky, what's that one called? Eschaton, that's the one.
The answer is no. No, the theory is if you have money to pay the difference, then you will have to use it for your total care. So it does, you're always limited by your resources.
I can
You're
answer some of
always
this.
limited by your resources. And that determines how you're going to pay for long-term care. And as I said, most of us cannot do it private pay. So we're looking for some way to assist us to do that. But if it's a couple you're thinking about, you've got 2 aging processes to finance. If you spend everything on the first one, the next one's left with nothing. So the theory on dividing the assets is to take care of both of you. But if you can afford Eschaton or Brookfield or some expensive place, they say you go ahead and do it, because no, they won't support that. No, no, no. Yeah. Yeah.
I can answer this.
Would you repeat it?
I will repeat it. You can't,
No,
you
not on
can't,
Zoom.
can you hear it? Okay. He wants to know if they would pay part, but they don't. This is the deal. And I've gone through this with my cousin. Originally, you had to pay down your resources to $2,000. Then it changed to $130,000 you could still have. And that's when my cousin got into it about 2 years ago. And then now it's completely up to what there's no, you can have as much money as you want. And it has only to do with income. But if you have a higher income, if you have 2,000 or more a month in Social Security, you will not qualify for Medi-Cal right now. However, it's getting even more complicated because they're going to vote on a new thing where they're going to go back to the $2,000. We don't know whether they'll vote that in. So it's kind of in flux at this time. But anyway, number one, you get them on Medi-Cal. That's the first thing you do. And if you can get somebody on Medi-Cal, then you can get them on a waiver program. And the waiver program will limit the amount that they have to pay in that facility. But there are only certain places that accept the Medi-Cal waiver program. So you have to find a place in California that accepts it, and that is very difficult. I only got one place that actually called me back and would accept it.
Can I
Well,
ask?
no, I got her in. But it took about a year to do this whole thing.
Holly, did you ever consult an elder care attorney who would walk through all of these
No,
things that need to be? No, it is-
Because Kaiser helped me with the whole
Okay,
thing.
so thank you. So you have to talk to your healthcare system, probably your doctor to begin with, and then the healthcare system. Hope you get somewhere and you can get answers. Certainly call Alzheimer's Association, see what they have to say. And then the resources that Barbara put together will show up after the recording that you receive. In fact, all of the recording have resources and links to them and telephone numbers and so on. So at least we will give you a beginning. You have to do the work, but you'll at least have a beginning. We don't have a list of elder care attorneys. So you're on your own on that one, but you should be able to ask about it, look them up and so on.
Senior Care Solutions can refer you to RCFEs who accept Medi-Cal. And also, if you contact Del Oro will give you one consultation with an elder law attorney. You also have the option, they may provide for you respite care for a certain amount of time, free of charge to you, depending on their grants. And the third thing, they will connect you with a therapist and pay for 6 sessions with that therapist. That's Del Oro Caregiver Resource Center, which is on your list. And Senior Care Solutions will help you find the RCFE who will take Medi-Cal.
And these resources help with all kinds of care, not just dementia care and caregivers. My sister used Del Oro when she had cancer. They were incredible and didn't cost her anything, which was so helpful when you're sick and you have, all kinds of costs. Anyway, Susan. Okay, thank you. We can't hear. Okay. There are brochures on the table. Please help yourself to all of them. This is our last session. Please take them all home. Share them with friends. Take multiple copies. So you can begin with those. And a lot of those help you think about what you know and find out what you don't know and to give you a start on maybe where to turn next. But there are some really good resources in Sacramento that we should take advantage of. Any more questions?
Could you talk a little bit about the resources and how you pursue that through the bigger healthcare systems? We know a lot of people in common, and the message we're getting is to, if you have any cause for concern, to immediately start talking to your physician, but then immediately call patient services and really be diligent. Do you have any sense about resources available at the Med Center, or in this case, Kaiser, that would help you with that? Sutter, sorry.
I do know Kaiser has mental health services dealing with dementias. I've not heard back how successful that is for people, but it's a place to start. I'm not really familiar with any of the other systems.
Well, Kaiser has an elder care. You can look up elder care. And then from there, you can get those kinds of things. I know that.
So when we were pursuing Kaiser, they referred us to a particular person. There's a complicated system. They referred us online, and there are zillions of resources online through Kaiser, but it is finding a real link. And then being as persistent, because it appears that there are a lot of resources, but getting that real link, I don't know if that's your experience as
You
well.
have to be your own advocate, no matter what the system is. You have to have knowledge and ability to speak up and to be persistent. Yeah.
They will actually help you with at Kaiser, they will help you get the Medi-Cal. If you find the Medi-Cal people, they will help you get your application in.
That's
And
good
I
to know.
found it very helpful.
That's good to know.
And I called them again recently, so they still have
Miranda,
that.
Miranda has a question also.
We're focusing a fair amount on Kaiser. UC Davis has an extensive, they call it healthy aging. They have support groups. They have social workers who will meet with you on a therapy level. They have a really amazing program. Sutter has a good program. I don't know as much about it, and I don't know about Mercy's. But at this point, most healthcare agencies, organizations have something, and all benefit to the fact that Jan knows a lot. Many, many, many primary care physicians don't know squat about this. They do the mini MOCA, which is what Trump has and says that he's a genius, right? And they say, oh, they're fine because they tested well on it. And so a lot of our primary physicians really do not have the education about this subject. And so being a bit of a pit bull in terms of being out there and being aggressive and being assertive about what you need and what your needs are is critically, critically important. If you're passive, you'll get nothing unless you just happen to have had Jan or Barbara as your physician.
Just a note on the mini mental state, which is simply a screening exam. It's not a diagnostic exam. I know it is, but it simply screens to say, maybe you should look at this more closely. Yeah. So
This is going back a little ways, but I have a couple of friends who have been diagnosed with mild cognitive impairment. To help me understand, would that be considered a progressive issue?
In some cases, it is. Mild cognitive impairment in and of itself is a diagnosis that's made when you do on the 30-point mini mental status screening that your score is, I believe it's 26 or 24 or below. Okay. So it means you missed a few points, but you have no evidence of impairment in any function. So you can still do everything for yourself. There's no obvious impairment in function or in decision-making. And in some patients, the mild cognitive impairment just stays steady over time. But having mild cognitive impairment is a risk factor for developing dementia as time goes on. So it may be, some people consider it, oh, it's maybe the very early stages, but there's no impairment in function, so we can't make a dementia diagnosis. So it's something that is generally followed over time, but it doesn't necessarily progress. There are some people who stay at exactly the same level over time.
Holly, behind you, behind you.
The neurologist, at least in our case, is the one who's going to decide when he goes from MCI to dementia, regardless of his ability to make decisions. And I've seen that in other situations as well. So it's none of it is black and white or cut and dried.
You are exactly right.
This is sort of a comment, sort of a question. The focus today has been on people providing caregiving for people who are at the stage of dementia where they're needing help with the ADLs, the activities of daily living. But there's a broad spectrum of caregiving that happens before that, that I think there are a lot of people who they're doing caregiving, but they're thinking, well, I'm not helping somebody with ADL, so it's not caregiving. And then they are really hard on themselves for, well, why am I feeling so burned out? I'm not doing caregiving. But there's years of gradually taking on more and more responsibility, but it doesn't meet this threshold that's called caregiving. And I wonder if you could comment a bit on that.
Very good.
Yes, if you're a caring person, you can always find somebody who needs something. Yeah, but we don't really see that as caregiving. One of my best friends is losing her vision. And so at least once a week, I go over and read her mail, copy down phone numbers, the things she can't read. I don't see that as caregiving, and I'm a lifelong caregiver. But it does take time and it does take effort. And I think we don't categorize that as something that should make us tired. But often it does, because as time goes on, it's going to involve more help for her to stay where she is. And I think you're absolutely right. We kind of slide into that without realizing we're becoming the caregiver.
Piggybacking on that is an emotion, an attitude that we haven't mentioned, and it's called guilt. And in the Jewish community, we are very, very good at Jewish guilt. But in the early stages, you know, there's this need, as you were talking about, to just keep doing what we do because that's what we do. And if we're dealing with a person who doesn't appreciate what we're doing, but we feel guilty about some of the actions on either side. So I was wondering how you address the guilt factor in caregiving.
Especially when you have to put somebody in a care home.
Yeah, guilt happens all the time. And I tell people guilt is like a backpack full of bricks. And that's a heavy, heavy load to carry. And guilt, you know, is a legitimate feeling. If you're doing something wrong, you know it's wrong, and you do it anyway, you should feel guilt. But what most of us are labeling with guilt, I tell them erase that word and use regret. I regret that the situation is such as it is, but I have no choice. And that comes with placement. People say they feel guilty, but there are no good options, no good answers when it gets to that point. It's either you're going to die or this person's going to die. So I have to make the choice that causes the lesser amount of harm, and that's placement. But take that word guilt and take that backpack off that's full of bricks, because most of us should not be feeling that. It's regret. I regret that the situation is this way and I have no other option. That's my take on guilt.
I'm curious, all the statistics that you have given are American, which is very understandable in this situation. But I'm curious, the percentage, not by numbers, but the percentage of dementia, is it the same in other countries or is it higher here? And then secondly, how do other countries handle it? Do they give more government support to the care situation? I'm curious how we differ, if you know.
That's a really good question, and I'm not certain about the incidence in other countries. I suspect the incidence of dementia is largely related to when the dementia diagnosis is made. Okay, so I think worldwide, well, and in this country as well, dementia is not always diagnosed until very, very, very late. So I suspect that countries that are better at diagnosing dementia further upstream may have higher numbers, incidence rates than we do here, but I don't know for sure. I can tell you, I don't know about a lot of the other countries, but I can tell you just from personal experience, my family is from Italy, my extended family, grandparents. So when we went back there last time, we actually walked by a building that looked like almost like a little hospital. And so the person who was walking with us, I said, "What is that?" And he said, "Well, that's a skilled nursing facility." And I kind of looked at him and I said, what kinds of patients go there? And he said, "Well, people with dementia." And I turned around and I said, "But at least in this small town on Lake Como, the mentality was, and the practice still, at least in our family, our extended family, was you take care of your own." And so that's what happens a lot, at least in that small community. And then he turned back and he said, "Well, you can see why most of it is closed up." He said, "Most of it is not in use because most of them are with their families, their extended families in these large houses." And so I suspect a lot of, in different countries, it's a cultural aspect of, families from multiple generations providing care. But that's a really good question. I don't know the answer about the incidences.
And that was true for this country too, before World War II. When families stayed in the same geographic area, you were born and you died within 50 miles. And after World War II, and we had the freeways, not freeways, but highways, and everybody started to scatter. And I come from a family where we cared for my great-grandmother who had dementia, and we all shared it. But everybody lived there. And so we were all available. That's not true anymore. And also countries that have medical care for everybody often have better arrangements for dealing with seniors and their problems than we do in this country. Yeah.
And I would think that with dementia, they probably get, I'm assuming, the same kind of early diagnosis and care because of the social medicines in many countries. However, when I first began to research, and we started with end-of-life issues, and in other countries, I found out they talk about dying and death frequently. We don't hear. I think we're beginning to catch up. We are beginning to talk about death and dying and preparing so we can have an end of life that is according to our values and our goals. They do that in other countries. And the one I love the best, and I think it was from the Netherlands, it could be Switzerland as well, and other countries, they have death cafes. They're like coffee houses. Now, coffee houses in the Netherlands are marijuana dispensaries, and they're called coffee houses. So I'm not talking about that, although that's certainly helpful. I'm talking about deaf cafes where people drop in, where they have meetings, and they talk about end-of-life issues. They have questions. They have people to answer them. They like a support group, and they share what's on their minds and where to go for information and all that. I hope that happens here. I think it's beginning to. I think Compassion and Choices in other organizations, maybe Hemlock Society, maybe the other, and Final Exit organizations probably are talking a lot more about end-of-life issues with their membership. And I think that's very hopeful for our country, but certainly it's not prevalent.
Oh, I had a question for each of the speakers. As I'm a long-distance caregiver, I would say my mother is 99. She has maybe mild cognitive impairment. I was sort of advised by a Jewish family service down there in Southern California years ago that she would be much happier for as long as she could to be near her very extensive circle of family and friends. Now it's just a few friends. I'm just curious, at various stages, I know people in Sacramento who have moved their elderly relatives here. What have you observed in terms of how well people adjust, especially, say, in a residential care facility?
Yeah, anytime a person with dementia is moved, it's traumatic. With dementia, you still can do some things if you stay in your same environment. What I said the first time I talked was you don't change that environment because then they can't function. They know where the bathroom is. They still can get there. You move them someplace else or even go stay in a hotel for the weekend. And they're very much more confused because they don't know where things are. And we have what's called motor memory. Our body remembers things. And so if we're in the same environment, we can function. But you take them out, and sometimes you have to. I mean, that it doesn't mean you can't move them, but you really need to think about it. I have a client whose daughter moved her sister, who they were very close, to another state. And the sister had dementia, and she's gone down rapidly because of that, because she can't function. So I think if the person can stay in their familiar environment, they do better than if they're moved. But if you're moved to for residential care or long-term care, they're going to do worse for a while, but they do adjust and adapt eventually.
Yeah, when people with dementia move, they're much more prone to developing what's called delirium on top of it. So that generally, as Barbara said, is something that resolves over time, but it can take weeks to months. And especially if they have more advanced dementia, when they change surroundings, they are completely in a different environment. They just have significant delirium. So you know, generally speaking, if they still have people around in Southern California who are helping ground her and she's in a familiar environment, that's fine. Sometimes I had patients whose parent, for example, was living elsewhere and that parent had no one else left. And so, yes, the family members moved the parents back. And Barbara's right, it takes a while, but generally they do get past that. But it can take a while.
One of the things that we always recommend is when somebody is being moved, because we have to, is to keep as much familiar as you can. Yes. So to make sure and bring lotions that they would have used, so that, because smell is a primary memory key. To use a cologne that people think, well, but they have dementia. Well, make the smell the same. Make sure that their quilt that they've always been wrapped in is the same. Make sure that some of the things that are in the room are stuff that would be familiar to them, and that can help, not to the degree that it fixes things like where the bathroom is, but it can be really helpful to have some of those primary things.
Yes. And that's why we advise when people are placed in a facility that the family member who's arranging the placement put up as many pictures on the walls and on the tables as they can. Anything to help familiarize them in their new surroundings.
And my mother was in a larger home in the Pocket area. And they told us we couldn't visit, I think it was for 3 weeks or 6 weeks, I forget what, so that she could get acclimated because she wanted to go home. But she was at mid-stage or later with Alzheimer's. And within that period of time, they were right. She forgot about her other home. So every time she got a visitor, she didn't say, okay, we can go home now, because she used to do that. So it took time. They knew what they were talking about. It was hard not to call, talk to her, visit or whatever, but she did get acclimated. But at the beginning of dementia, I don't think they would be in a facility anyway. So, but mid or late, I think they do adjust. It just depends on how much they can remember.
Yeah, I also tell the family, just because you can't go and visit and talk to them, you can always call and talk to the caregivers. How is my loved one doing? So you can keep track of them that way.
I grew up in Morocco, and in Morocco, there were no facilities at all for older people. When for my grandmother, when she got old, she came and stayed with my mother, and she stayed there, and it was assumed that she will be with them. And then even when my mother moved to Israel with my siblings, my grandmother came along also, and then she stayed with my parents until she died. And it was assumed like that. And I've never met anybody in Morocco, that is. In Israel, yes. I never met anyone who went to a facility. Never. But I came here to this country when I was much younger, and I will never stay with my children. I will go to a home. See, it's just where, where you were raised and where you live, and what the customs were. So I will never assume at all that my children are going to take care of me. I don't know.
I wanted to just jump on what Miranda said a little while ago, that while those of us that are in the middle generation of taking care of parents, and some of us have kids that have special needs, we might not be direct caregivers, but if we are, like for my stepmother had Alzheimer's. Her daughter didn't do anything because she lives in Florida. My dad lives a couple hours away from here. My sister and I were the ones that found the caregivers. By the way, care.com is an excellent resource. If you don't want to pay it was going to be $42 an hour through a service. We had somebody $25 an hour who arranged everything and never missed a day and had 3 people. So, and this was down in the Bay Area. So Cupertino, which is certainly not cheaper than here. So, but we were the ones that had to do everything. We're the ones that, recently moved my father, who's 93, into a not assisted living, independent living, because God forbid he would do assisted living, and worked on, clearing out his house. So while you're not a caregiver, it's a lot of work to do all of that stuff. And while there isn't a title for it or whatever, I think we need to remember that that's a huge emotional and time sucker. And even though you're not doing a day-to-day caregiving, I think we need to think about more resources for even those folks.
I call that caregiving. When you're, it's not day to day, but it's a lot of work. And
It's on your mind. It's on your mind.
And it's on your mind all the time.
Right.
You worry
right.
about it. Yeah.
Are there any more questions? These have been fun, wonderful questions. Any more questions?
Not necessarily a question, but the stage after, when somebody's passed and died, and what Jan's been talking about at a hospice, and what you're talking about, grief for a caregiver is so much more than it would be like for another family member who's not. And the reason is exactly what was just said, is all of your mind as, oh, well, wait a minute, can I do this or should I do this because I need to worry about them? And all your decisions are rooted. And when that's gone, there's this void that's huge. And so the caregivers need a level of support after someone has died that far surpasses probably any other family member who may have guilt for not having helped or whatever, but it's the caregiver that needs support after. They need caregiving.
I would add that that's part of their identity, becoming a caregiver. So you lose the person and your identity, and you lose the ability to love that person.
Among the articles and pamphlets and so on the table is Einstein Jewish Community Service presents caregiver support. And Rabbi Denny Marshall, who has been a speaker with us once, has these support groups. So definitely take those. Thanks, Sheila. Thank you all. Carol, go ahead.
I just wanted to say that I was with my mother when she was in the very early stages of dementia, Alzheimer's, and didn't know what was happening. I knew there were some strange things happening that I couldn't account for, but it never even occurred to me that it was that. And then over a period of 8 or 9 years, because she moved from Sacramento to Florida to be with my sister, and she was there for several years and then moved to New York State to be with my brother. But in between those various places, she would come back to Joe and I and stay for a couple of weeks at a time. So I saw her in all the stages of Alzheimer's. And, you know, the most, the one that was the most challenging was that she had sundowners. And every day, even after we'd had 4 walks during the earlier part of the day, Joe and I would take turns going with her and didn't really want another walk. And we would lock the door, close the blinds, trying to convince her it was nighttime. And she would bang on the door and have a little conniption because she couldn't get out again. And then she would calm down, you know. And every night she took a bath every night, and she would go in the bathroom, fill up the tub herself, and then she would get, you know, dressed. And then half an hour later, she would go in the bathroom and start filling up the tub again. I mean, there were regular routines. But even at the very end, and this was just weeks before she died, and my brother left her with Joe and me because he had to take care of something. And he and his wife had taken care of her for the previous 5 years. They were just wonderful. And there was a part of her, even though she couldn't swallow anymore, she couldn't talk. And she was very calm then, all the time. But she didn't forget everything because she loved to dance. She loved to dance all her life. And she was small. She was very 4'10", and by then there was hardly anything left on her bones. And I would put her feet on my feet and put the music on and dance with her. And you could see, you know, even though she couldn't talk, you could see how happy she was. And so, you know, it's a very hard. I don't know what it's like to be a full-time caregiver because these were sporadic visits. And I know how hard that is even for that amount of time. And I wish there were more younger people here because those of us who are as old as I am or close to it, we don't have parents anymore that we're going to have to worry about caring for, maybe not spouses either. And anyway, just, you know, I know there are resources now that didn't used to exist. But if they used to be at the senior center on J Street, they had a program that I would take my mother to in the daytime, because they would have entertainment. People would, they'd play the piano and they'd sing, and it didn't matter what stage of Alzheimer's you were in. So, I mean, because they participated and danced. And anyway, just there's some upsides to it, and it's still in there, the person you knew and loved.
Thank you, Carol. And I think last time Meg mentioned that. I mean, a lot of that. But they may not be able to communicate, but there's somebody inside. And whether it's music, dancing, fragrances, textures, whatever. And that was really important knowledge, because I've been through this a couple of times and I wish I had known that. Because my visits, like so many of ours, would be really quick because they didn't know me anyway, right? It's a whole different, when you have the information, it's a whole different perspective. So I hope that all of us have, Barbara?
The program you were talking about in J Street is RRR, and they still have that. Yes.
It's on the list of
Yeah.
resources.
And what a beautiful thing you did for your mother.
Yes.
That was so sensitive, beautiful. Yeah. Yeah. But
Thank you. Carol just said that her brother and sister-in-law took care of your mom to the end. And yes, takes a lot.
Also, for those of you that are on Facebook, there's a group called Parenting Aging Parents. And I joined it like a year or so ago. And it's wonderful because you can talk freely. You can just read other people's things and go, oh, I don't have it quite as bad. So, I mean, it's Parenting Aging Parents it's a private Facebook group.
Parenting Aging Parents on a Facebook group. And it's a support group online. You can learn all kinds of things from other people who have gone through it. I've been through and I don't know if anyone else here has been through the support groups through the Alzheimer's Association. I've done that. So helpful. Like you said, Barbara and Jan, to be among people who you don't have to explain anything to or everything to. They know, they're there, and they go along the journey with you. It's very important. It's a calming effect, I think. Anyway, moving on, I want to thank you all for your questions, and certainly to our speakers for their informative answers. Barbara and Jan and Meg, thank you, our former speakers. We appreciate you being here and sharing your knowledge and expertise so that we can take better care of ourselves if we are or become caregivers. And I think you've gotten the message. It's never too early to start planning. When you think you're going to become a caregiver because of your position in the family or whatever, or where you live in the country, you have to start planning, because what you don't know can hurt you and anyone you're going to end up taking care of. So I'm very happy that you now know more than you did before you came today. Considering the dementia risk will double to about 1 million people a year by 2060, and as the U.S. population ages, the information we heard today and in the last 2 programs will help you plan, and your loved ones plan as well, if dementia is in your or their future. We suggest you read the Compassion and Choices Toolkit, especially the dementia values, which is inside. It's a number of pages that walk you through with questions that you can think about and answer. And then when you have an answer, at least for this point in time, fill it out and attach it to your trust and your wills. And then the doctor should know, the medical center that you're part of should scan all of this or any other forms that you use. I have seen other forms They just weren't as user-friendly. I find this very user-friendly because it walks you through situations so you can think about them instead of having a blank number of lines saying, what would you do if? It's like, I don't know. I never thought about this. No one's ever talked about it. This will help you think it all through. So we really like this, my end of life decisions, advanced planning guide and toolkit, and there are a number of them. And I know a lot of you already have them and you have multiples. Take more and pass them out and talk to people about this. I would like now I'd like to review what I consider some very important takeaways from the 6 Wise Aging programs that we have done since October 2023. Number 1, planning for a health crisis and the end of life is an act of love, guidance, and support for your family members and other loved ones. It's a reflection of your values and your goals for healthy aging and beyond. Number 2, aging and dying people must be able to retain their dignity, integrity, and self-respect. Too many terminally ill, extremely frail patients end up in the emergency room, where they endure invasive procedures and treatments that diminish their quality of life and take away their dignity. To avoid this as much as possible, fill out the Compassion and Choices forms and give copies to your healthcare system, doctor, agent for healthcare, so they know your wishes. Number 3, the default mode in our current medical system is to extend the patient's life regardless of the quality of life, even for people with advanced dementia. So I encourage you to create your personalized end of care plan using the toolkit. You can always change and update it as long as the people who have copies know that you've made the changes. 4, and for you now with your doctor and when in the hospital in the future, and Barbara and Jan have said this, we have said this over and over, be an advocate for yourself and anyone you are caring for. If this is not your style or you think you shouldn't be pushy, think again. You must tell your doctor what your wishes are. You must ask questions and keep asking until you get answers. Ask for health care options from aggressive care to comfort care and everything in between. Know that you have the right to decline medical treatment. Doctors have a habit of dictating the care they think you should have rather than discussing options and consulting with their patients about their care and wishes. I am sure many of you in this room have been involved with the medical community. It's not intentional. It has to do with training, being too busy, the changes our healthcare system's going through. So you have to look out for yourself and the person you're taking care of. Only with open and honest dialogue will you receive the care you deserve that fits your life goals. 5, too often our healthcare system denies us the ability to make informed decisions throughout life and at the end of life. Know what you want and ask for it. And after all of these programs with these wonderful speakers, you should have a better idea of what you want and how you want to proceed. I hope all the information you've received doesn't overwhelm you. Instead, use it as a starting point to think about your values and needs and talk to the people in your family and to your doctor about them. Let them know that you want to be heard and included in all decisions that involve you or the person you're taking care of. And remember to advocate. And now I'd like to recognize and thank the dedicated team members who planned all of these programs. Susan Abrams, Laurel Hollis, Holly Ilfeld, Barbara Milgram, Ellen Savage, and Sheila Wolf. Thank you. The recordings all have resources listed at the end, so do look for them. Thank you for coming and for being open to learning and sharing what you have learned. Goodbye and happy, healthy aging.